We're going to start talking about management of patients with complications from heart disease, part 1. Here's your list of objectives, so make sure you're reviewing these once again so that you know this is what you should be expected to be familiar with for the exam. Heart failure is a clinical syndrome resulting in structural or functional cardiac disorders that impair the ability of the ventricles to fill or eject blood. In the past, heart failure is often referred to as congestive heart failure because many patients experience pulmonary or peripheral congestion with edema. Heart failure is recognized as clinical syndrome characterized by signs and symptoms of fluid overload or inadequate tissue perfusion. The term heart failure indicates myocardial disease in which there's a problem with the contraction of the heart, which is considered systolic failure, or filling of the heart, which is diastolic failure. Now, a lot of this should be familiar from previous semester's lectures, and even from our rhythm interpretation lecture, we talk about systolic and diastolic, relaxation or contraction. Some cases are, and going on to some of these cases are reversible depending on the cause. Most heart failure is a chronic progressive condition which can be managed with lifestyle changes and medications. Acute heart failure is heart failure that develops suddenly, for instance, after a heart attack due to certain heart rhythm problems. Chronic heart failure usually develops gradually over time and can result from different medical problems. For example, permanently high blood pressure, uncontrolled blood pressure, those things. Patients with ventricular failure of any type have low blood pressures, low cardiac output, poor renal perfusion, poor exercise tolerance, and heart dysrhythmias. Remember, we talked about some of the dysrhythmia lecture about how when you have a rhythm and your heart isn't able to pump properly, beat properly, you're going to have low cardiac output, and think about how your patient's going to present. Abrupt onset as with acute MI or subtle onset can be subtle progress resulting from slow progressive changes. In both an acute and chronic heart failures, the body's response to low cardiac output is to mobilize compensatory mechanisms to maintain cardiac output. We'll talk about this more later, but just keep in mind, like everything your body is trying to do is always maintain homeostasis. So everything that's going wrong in your body is trying to find ways to maintain balance. There are two primary risk factors for heart failure. You got your hypertension, which is a modifiable risk factor. When properly treated and managed, incidence of heart failure can be reduced by up to 50%, and then coronary artery disease. Some of the comorbidities that contribute to development of heart failure are diabetes, metabolic syndromes, advanced age, tobacco use, and vascular diseases. Heart failure can be caused by many other conditions. Page 819 and 820 is a good list of those conditions. Like we talked about, long-standing hypertension, coronary artery disease, MIs, and diabetes are also items that can cause heart failure. That can be caused by heart failure. And just keep in mind, anything that interferes with normal mechanisms that regulate cardiac output, those are things that can cause heart failure. Cardiac output depends on your preload, your afterload, your contractility, and your heart rate. So I know this is kind of a recap coming back to you from first semester and second semester, but remember, anything that changes any of those factors is going to lead to decreased ventricular function in heart failure. Cardiac output is the volume of blood in liters that is the heart pumps per minute. It's calculated by multiplying the amount of blood ejected from the ventricle with each heartbeat, which is your output equals stroke volume times heart rate. Contractility is the strength of that contraction. So remember, this should just be coming back to you, just trying to bring it back into your memory again. Drugs that improve your contractility are positive inotropes. That's going to be your epinephrine, norepinephrine, dopamine, Millerone, and some other drugs that reduce contractility are going to be like your calcium channel blockers, your beta blockers, and some clinical conditions as well, like acidosis, can also reduce your contractility. So if you think about it, if you increase the contractility, that's going to increase your stroke volume, and it's going to increase, but it also increases your myocardial oxygen requirements. So there's always a balance. If you look at medications, that's going to improve how hard how well your heart contracts, but you have to think that it's going to have extra requirements that it's going to make it harder as well. Remember, your preload is also known as the left ventricular end-systolic pressure. It is the amount of ventricular stretch at the end of diastole. So think about it as a heart loading up for the next big squeeze in the ventricles during systole. Some people remember this by the analogy of a balloon. Like if you blow in the balloon, it blows and it stretches, and the more you fill it with, the greater the stretch. Afterload is known as the systemic vascular resistance. It is the amount of resistance the heart must overcome to open the aortic valve and push the blood volume out into the systemic circulation. So once again, if you think about that, a balloon, the afterload is represented by the knot at the end of the balloon to get the air, or those annoying little clamps that they have on the balloons now instead of a knot. But if that's just what it has to work out to get the air out. Preload and afterload and contractility determine the stroke volume, and cardiac output, and blood pressure. Increasing the preload, contractility, or afterload increases the workload of the heart muscle, resulting in increased O2 demand. So here's a quick, if you're into diagrams, here's a quick diagram of pathophysiology of heart failure. You're welcome to review it and look over it if it helps you kind of piece it all together. Remember, every heartbeat has two distinct phases. You got your systole and your diastole. Remember, systole, that's when your cardiac muscles contract in unison. Okay, and if you look at the heart, it makes the heart twist a bit and propelling blood into the lungs and the body. Diastole is where the muscles relax, and this is the four chambers expand and fill with blood as it relaxes, the blood pulls pulls the blood into the ventricles. Heart failure is increasingly being classified as based on the pumping ability of the heart. This is because the pumping ability plays an important role in choosing the most suitable medication. Then an assessment of the ejection fraction is performed by an echocardiogram to help assist in determining the type of heart failure. The ejection fraction is the percentage of blood volume in the ventricles at the end of diastole that is resulting during systole. It's a measurement of contractility. So you think about it, it's the amount of blood that's pumped, that's left ventricle with each heartbeat. Rough number, for example, like if your heart pumps out 100 mils, after it contracts, if there's 40 mils still in your heart, that means 60% was pumped out. So you've got an ejection fraction of 60%. Normal ejection fraction is roughly 55 to 65%. The ventricle, like I said, doesn't completely empty between contractions. The patients with heart failure with reduced ejection fraction generally have ejection fractions of 40% or less, and it can actually be low as 5 to 10%. You don't need to do the calculations. I'm not going to give you it, but just to be understanding, you subtract the amount of blood present in the left ventricle at the end of systole from the amount of blood present at the end of diastole and calculate the percentage of blood that's ejected. Kind of like that example I did just previously. There are two major types of heart failure identified by assessment of the left ventricular function, and usually this is done with an echocardiogram. Both types of heart failure result in the same thing. The heart has trouble supplying the body's organs and tissues with the blood they need. There's systolic dysfunction, and then there's diastolic dysfunction. And remember, so in systolic dysfunction, it's a deficit in ventricular ejection, and diastolic is a defect in ventricular filling. So remember, ejection fractions, you've got low is reduced in systolic heart function, and normal preserved is your diastolic heart function. Systolic heart failure is the left ventricle becomes weak and flabby, not able to contract forcibly, and loses the ability to eject blood. So if you think about, remember, we kind of talked about a balloon earlier where you keep filling it up with air, and if there's a lot of pressure and the volume's always there, it keeps stretching out the heart, stretching it. And after a while, when you blow up a balloon, a lot of times it doesn't have that ability to reclose back. It doesn't have the ability to contract tightly again. And that's kind of what you're looking at, a systolic heart failure. A diastolic heart failure is the left ventricle stiffens and bulks up. It can contract forcibly, but it can't relax afterwards because of the stiffening. So it has decreased filling. So kind of like that, it's like your ventricles are working so hard that it's it's pushing against so much pressure, it's building up, and as it works out, it builds up, it bulks up. Well, what happens is then, it can maintain your output, it can maintain the ejection fraction, so it's pumping out the same amount of volume, percentage of volume. Problem is it's bulked up so much it can't relax. So that's the two sides of the concerns with that. Left-sided heart failure causes different manifestations than right-sided heart failure. We're going to be discussing those shortly. Some chronic heart failures can have signs and symptoms of both left and right ventricular failure. So it's not always cut and dry which patients have signs and symptoms of, possibly both. Here's a quick just breakdown of two of them. You've got your right-sided sign symptom manifestations. You've got your visceral and peripheral congestion, jugular vein distension, dependent edema, hepatomegaly, ascites, and weight gain. And on your left side, you've got pulmonary congestion, S3 or ventricular gallop, dyspnea on exertion, low O2 saturations, dry non-productive coughs, and oliguria. So if you notice this, the left side is mainly pulmonary side effects, and manifestations. Your right side is mainly venous throughout the body. So a quick thing is left side, left is to the lungs and the right is to the rest. A student told me that last semester, and it seemed to help everything make sense. So if you're talking about heart failure signs, symptoms, if it's like what side is what side is failing, if they've got pulmonary congestion, you're probably looking more at the left side thing. If they've got edema and jugular vein distension, then you're probably looking more at right-sided issues. Left-sided heart failure is the most common form of heart failure. It results from the inability of the left ventricle to either empty adequately during systole or fill adequately during diastole. The left side of the heart has to work harder to pump the same amount of blood. So left-sided heart failure results from ventricular dysfunction. It prevents normal flow, forward blood flow. Blood backs up into left atrium and then pulmonary veins. Increased pulmonary pressure causes fluid leakage. And this is, you're looking at pulmonary congestion and pulmonary edema. Early signs of left-sided heart failure are going to be your increased pulmonary venous pressure, which is you're gonna start having increased respiratory rate. You're gonna have decreased impartial pressure and your PaO2, and as you progresses, you're gonna have interstitial edema. Tachypnea develops as the patient becomes more symptomatic, short of breath, and then further progression is when the blood your blood is backing up into the lungs, it's backing up into the alveoli, and it's you're losing area to do your gas exchanges, which you're going to be looking into respiratory acidosis, right? Because if you can't do the gas exchange for oxygen and CO2, you're going to retain more of your CO2 going into that direction. So your left, and here's just a quick resummary of that. Left ventricle can't handle the overload of blood volume, resulting in increased pulmonary pressure, causes fluid to leak and move from the pulmonary capillaries into the interstitial space in lungs and alveoli. Left-sided heart failure will present with pulmonary signs and symptoms. Remember, left is to the lungs, right? Here's normal, and then as instant here, you've got blood backing up into the alveoli. So some acute events results in left ventricular failure. As left ventricular begins to fail, blood backs up into pulmonary circulation, causing pulmonary edema. Like we talked about, results in hypoxia, often severe. Clinical manifestations. So these are things. What do you think about when someone can't breathe? They're restless. They get anxious, dyspnea, cool, clammy skin, cyanosis. They're weak, rapid pulse, cough, right? Lung congestion. Remember, we talked about respiratory concerns with left-sided heart failure. Increased sputum production. The sputum may be frothy and blood tinged, right? So if your blood's backing up into your alveoli, when you're coughing, that fluid can be mixing with your saliva, and then you'll be coughing out blood as well. Decreased level of consciousness, right? If you can't do appropriate oxygen exchange or CO2 exchange, you're looking at those signs and symptoms as well. Acute decompensated heart failure can manifest as pulmonary edema. So this is the alveoli are filling with fluid, like so right here. Most commonly associated with left-sided secondary to coronary artery disease. So this is kind of just rephrasing it and re-summarizing what we've talked about. It's kind of I think it's a good representation, kind of a good visualization of the fluids backing up and filling into your lungs. So generally pulmonary edema, the cough associated with left ventricular failure is initially dry and non-productive. And then, but remember, the absence of crackles does not rule out acute decompensated heart failure. A lot of patients with chronic heart failure have developed increased lymphatic drainage of the alveolar edema. So, like I said, your body is always trying to find homeostasis, and it's going to do what it can do to kind of protect itself. So, if it's a chronic issue where your body has time to fix itself, it can actually work out pathways to have additional drainage of the alveoli to help with the backing up of the fluids. Management of pulmonary edema is easier to prevent than it is to treat early, because once you start going to respiratory distress, you're going to start having more of those. You're not only do you have heart failure, now you have lung failure as well, respiratory failure, and then you're going into respiratory acidosis and those things as well. So that's a lot more things you have to worry about. So it's easier to focus on getting, not getting to that point. So obviously recognizing it, monitor lung sounds for decreased activity, tolerance and increased fluid retention, right? So if you're having increased fluid retention, you're going to be listening for like crackles and those kind of things. Minimize exertion and stress. Put them on oxygen, a non-rebreather if need be. Give them diuretics, furosemide, and vasodilators or nitroglycerin to help with those. Remember, position the patient to promote circulation. That's the first thing you do, right? If someone's having respiratory distress, if you can, you position them upright, legs dangling, right? That helps with that. Provide psychological support. Remember, reassure the patient and provide anticipatory care. Remember, if they are having failure and they have difficulty breathing and having this, they're going to be stressed out and they're going to breathe even faster. They're going to work even harder, and that's just going to exacerbate things even worse. So trying to provide support and help them, is keep them calm while you're working with them, will definitely save you troubles in the long run. Monitor your medications, I's and O's, right? You want to make sure with heart failure you're watching out for fluid retention. So generally you're going to have strict I's and O's, either Q1, Q2, checking of those, monitoring your including your IV fluids plus your PO intakes. It's important to remember. Left ventricle in systolic failure loses the ability to generate enough pressure to eject blood forward. And the hallmark of systolic failure is decreased left ventricle ejection fraction. So that's the HFrEF. So it's heart failure with reduced ejection fraction. So that's what you have a reduced ejection fraction. So that's when, like I said, that's a sign it's a systolic issue. Basically, over time, the eccentric hypertrophy occurs, and the ventricle becomes dilated. Remember, that's like that extra swelling. So that's the ventricle becomes swollen, stretched out, and then the weakened heart muscle cannot generate adequate stroke volume, which affects cardiac output. Right. So if, like I said, that whole balloon analogy, right, keeps blowing it out, keeps stretching. Eventually, it can't squeeze tight like it should. And then because the left ventricle cannot effectively push the blood forward, the diastolic volumes and pressures increase. Here's a kind of a quick picture. We're going to see normal, left atrium, left ventricle. Seeing when it's enlarged, systolic failure, notice it's significantly more volume can fill in there, and that's part of the problem. And then you've got diastolic failure, which is heart failure with preserved ejection fraction. That's going to be the impaired ability of the ventricles to relax during filling diastole. Over time, of the concentric hypertrophy occurs, thickening of the ventricular wall, which results in impaired filling. So, like I said, so it's bulking up. It's building up muscle mass. Your ventricle is getting it's getting buff. But the problem is then that all that muscle space takes up space to hold volume of blood. So you're going to be able to have high filling pressures because of the stiff ventricles, and you're going to have less volume there for less volume blood to be moved. So you're going to have decreased stroke volume overall and cardiac output. Because if less blood can get into your ventricle, then you're going to have less blood that can go out. So you're looking, and it's the same end as the systolic failure. You're going to have pulmonary congestion, interstitial edema, and impaired gas exchange. So, like I said, remember, whether it's a systolic or diastolic concern, if it's affecting the left side, it's going to back up into the lungs and it's going to cause respiratory concerns. Here's just kind of a visualization of diastolic failure. You'll see normal, and then here you got your thickened ventricle walls all through here. So all this area here is lost volume that the heart doesn't have anymore as far as it's putting out. So it's gonna, you're definitely gonna, when you pump out, you'll keep your ejection fraction, might be 55% to 60% like normal is, but the problem is instead of 100 mils in here, you've only got 60 mils. So your cardiac output is going to be decreased. Evidence of systolic dysfunction is verified by echocardiography or cardiac catheterization. It can show the size and the shape of the left ventricle and gauge how well it's functioning. Just kind of another image just showing how you have normal function, systolic dysfunction, and diastolic function. So you notice here you've got your enlarged ventricles filled with blood, and but because of that, they pump out less than 50% of the blood because they just don't have the stretch to squeeze it all in. And in the reverse, this way here, it fills with, you have less volume in here, but it's able to actually, the muscles are stronger, so they can still pump out the volume that's there. So eventually, when it is possible that you could have right-sided heart failure, and when the right-sided ventricle fails, congestion of the peripheral tissues and the viscera predominates. Right, because right ventricle fails to pump effectively, and the fluid backs up into the venous system. So you're going to have peripheral edema, abdominal ascites, hepatomegaly, jugular vein distension, weight gain due to your fluid retention. All right, because if it's backing up, it's going to move into the tissues and organs, causing swelling in the body, such as ankles and the legs. Because remember, you got your superior and inferior vena cava. They feed into the right atrium, go in the right ventricle, right? So if your right ventricle is not producing, then it's going to back up the right atrium, then it's going to back up in your superior and inferior vena cava, and then it's going to back up the rest of the body the rest of the way through. That's why I say right side is the rest of the body. Left is your lungs, the right is the rest of the body. Something to think about though is the usual cause of right-sided heart failure is left-sided heart failure. That's your number one culprit right there. Other causes can be right ventricular infarction, pulmonary embolism, cor pulmonale, which is right ventricular dilation and hypertrophy caused by pulmonary disease. If you think about it, and this is kind of how it causes, if your left ventricle fails, fluid's backing up in your pulmonary system, right? Our whole, the body is all interlinked, right? So if it's backing up into the lungs, it's gonna be eventually backing up into the right ventricle, which is gonna back up the right atrium and back up all the way through. So the problem is the right ventricle, since the left ventricle is unable to move the volume like it's supposed to, the right ventricle, which is significantly smaller in size, is having to move all the blood through the lungs out, into the left ventricle, and then help move it through the ventricle through the rest of the body again. So just that increased workload is going to cause the right ventricle to eventually fail as well, causing backup of blood through the whole system. Like I said, see, if you look at here, your right versus your left is your left definitely has larger muscle mass on the normal heart versus the right. It's because the normal function of the ventricle, the right ventricle, its only duty is basically to pump from here out to your lungs and to get it back into your heart. Your left ventricle's job is to pump it all the way out through the rest of the body. So, it's just your right ventricle is just not designed for that kind of workload. Here's an example of some pitting edema. So, like I said, this is generally obvious after retention of at least 4.5 kilos or 10 pounds of fluid. Everyone should be knowing how to chart edema, which is 0 if they're known, up to 4+, which is severe pitting edema. I would say if you can push into someone's foot and leave your fingerprints in there, and that's probably 4+ would be a safe assumption. In development of edema, a sudden weight gain of 2 to 3 pounds in one day is often a sign of decompensated heart failure. So remember, so that's a sudden weight gain of 2 to 3 pounds. That'd probably be a number to keep in your mind. Remember, not all lower extremity edema is a result of heart failure. You could have hypopertemia, immobility, venous insufficiency, and certain drugs, right? Yeah, so those all can cause edema as well. So if you have just because you have edema doesn't mean necessarily you're having right-sided heart failure. Okay, we just talked about this. Left is the lungs, right is to your heart, the rest of the body. Quick recap. Left ventricle of the heart no longer pumps enough blood, and resulting in pressure, blood building up in the pulmonary veins, and the blood is carried away to the lungs, causing pulmonary pressure. This causes shortness of breath, trouble breathing, and left-sided failure is the most common type. Right-sided, the right ventricle of the heart is too weak to pump enough blood into the lungs, causes blood to build up in the veins, and then increased pressure causes veins to push fluid out of the veins into the surrounding tissue. This leads to buildup of fluid in the legs, feet, and less commonly genital area, organs, and the abdomen. So that's the end of part one. Like I said, here's my calendar link. If you have any questions, you're welcome to reach out. And I will talk to you all later.